So this is the final plenary, and obviously we hope to, in our speakers and in the panel, draw together some of the macro and micro issues that we've been discussing over the last 2 days and think about how they can be addressed and are being addressed more effectively. So to begin the session, I'd like to call on Leonie Segal. Leonie holds the Foundation Chair in Health Economics and Social Policy at the University of South Australia and is involved in a research program concerned with improving the life chances of the most vulnerable members of our society. Leonie has an impressive record in research and across a range of issues and many insights to share with us today. Today, she's specifically tasked with exploring the role of economics in studies of rural and remote health. Thank you, Leonie.
Thank you for the opportunity of talking with you today. I must admit I prepared this sort of quite general title, and then I thought, because it gave me sort of a fair bit of scope to work out what I was going to talk about, and then it's like, okay, well, what of that can I encapsulate? Basically, over 30 years of research in 20 minutes, so it's going to be a bit of a race through. So I think a lot of people perhaps don't really understand what economics is about. So economics is a discipline which is concerned with maximising wellbeing, knowing that resources are scarce. So choices have to be made. And the questions we need to answer are what to produce, what's the ideal mix of services and programs, how to produce it, what's the optimal mix of resource inputs, to whom to distribute, who should we be delivering services to, and how do we actually achieve that ideal, how do we actually get the incentives in the system that are actually going to push us in the right direction, rather than we tend to have incentives which often are perverse and shifted away from where we really need to go. And a core part is actually how do we fund our health system for equity and efficiency. The other thing economists tend to do is take a systems perspective and a very theory and logic driven approach, which means often we sort of come at things from a bit of a different angle. So in terms of what to produce, the sorts of activities involved in that are what we call priority setting, and I must admit that was a sort of a focus of my PhD about 15 years ago, and that was really looking at if we want to reduce the burden of diabetes, how do we do that? And looking across the whole spectrum from primary prevention, secondary screening, secondary prevention, tertiary prevention, across modalities. So rather than come from a vested perspective, it's really, okay, if I'm trying to represent the best for society, how do we identify what's the most cost-effective thing to do? And if you think about it, if we invest in things which have low benefit per unit of cost versus things which have high benefit per unit cost, we are in effect wasting resources and we will not maximise the health of the community. It's a really simple logic proposition. So that's given rise to cost effectiveness analysis, cost utility analysis. Utility is basically a concept developed by economists, which essentially is saying that we can represent as best we can quality of life, effectively sort of perceived well-being on a scale from 0 to 1, or in fact we go less than 0 where 0 is dead, less than 1 is sort of states worse than death, up to 1 which is full health. And there's certainly states worse than death, and you do find them in the survey work. In fact, I was just on a meeting on stroke, and whether it's sort of stroke, people with severe mental illness. I mean, when you think about it, anybody who is committing suicide has decided they're in a state that's worse than death. The other thing that economists perhaps try to do is a lot more comparative economic evaluation. So rather than just looking at a particular program, it's thinking about, well, how does that compare with some other way we might address that problem? The how to produce, as I said, it's often about the sort of the workforce, the competencies, the skill set, what modalities. So are we looking at a clinical intervention? Is that the best way to proceed? Individual clinician, medical model, multidisciplinary, adult health, plus social, public health, social marketing, education, subsidies, penalties. It's quite interesting. I mean, I don't actually brand myself as a health economist. I mean, while I run a health economics and social policy group, often health economics is thought about the economics of the health sector, whereas my interest is much more around the economics of health and wellbeing, however that might be achieved, which is sort of a much more thinking in a cross-sectoral way. The whom to distribute, economists have done a bit of work around, really basic principles. Horizontal equity is a concept which basically simply says equal access for equal needs. So people who have equal, have a certain health condition, that regardless of where they are, what their socioeconomic profile, how much power or influence they have, they should actually get access to equal health services. Vertical equity is basically saying those with greater needs should get greater access to services. We don't do that very well. Any studies, I know sort of for instance studies of the Better Access program of providing psychological services through care planning. Lo and behold, we find most of those services are going to the more advantaged in in the sort of well-off areas. In fact, we I think a long way from actually achieving our horizontal and vertical equity goals. And in terms of this meeting, clearly regional equity. So regardless of where you live, city, regional, inner, outer, rural, remote, high, low SES, disenfranchised, the more competent members of society, how do we ensure that everybody, regardless, has access to what they need? I mean, that's your sort of ideal, and that's really underpins the principle of Medicare. We don't want to see people accessing services on the basis of capacity to pay, their location, or their power and influence. The other part of this question is how do we fund? How do we fund for equity and for efficiency? And we have a lot of, I think, really misinformation around the value of private health insurance or subsidising that, or that somehow or other that's saving government's money. In fact, every time the government supports private health insurance, it actually costs the community money. It in fact diverts resources away from the public sector, because you find that if there's more resources going into private, then they're competing away clinicians from public. So in fact, economists are absolutely unanimous that universal cover will promote equity and efficiency. Every community that's adopted that has found that they've actually been able to achieve better outcomes for less money. It's quite disturbing though that, basically when Medibank came in 75 under Gough Whitlam, was only after a double dissolution, and in fact the biggest opponents were the medical profession, and to what we're still probably seeing in the States. So then I had this sort of issue, what am I going to cover in this talk? I do quite a wide range of work over my career: burden of disease, priority setting, economic evaluation, health workforce, looking at outcome measurement metrics, defining research question. That's actually what I spend a lot of my time doing. If I've got a 3-year research project, I might spend the first 6 months, 9 months, 12 months really understanding my research question, because if you don't get that right, you'll never answer it. You need to understand your question, you need to understand the sort of causal pathway, what your problem really looks like. And I think a lot of people jump in thinking they know that, but not necessarily doing the really deep work to fully understand causal pathways. The other thing I've done quite a bit of work around is market failure, how we've got sort of massive distortions to our health service mix, which relates to our sort of mixed Commonwealth, state funding, and sort of some policy work, particularly around nutrition. And there's sort of, I've just got a few manuscripts which cover, a bit the sort of range of work I do, looking at the role of the patient in the health system, how health funding distorts the health service mix, bringing together economic evaluations, 245 economic evaluations, looking at there's one on economic evaluation of interventions for problem drinking. Do within family external effects make a difference? One of the issues when we do economic evaluation, we normally look at the outcomes for the primary target of that evaluation. But if you're dealing with a program that's going to affect family members, that's going to affect the wider society, if we don't capture those benefits, then those sort of programs will always look poorer value than those where the benefits are much tighter, and we're really poor at capturing wider benefits, and particularly in the mental health space, where we tend to find the impacts go absolutely beyond the individual. We do a really poor job at identifying those. The other, some stuff on costs of training, looking at community response to child maltreatment from an economic perspective, the nutrition strategy, and some work on, I suppose, needs analysis. I've done quite a lot of work on that. But what I've decided to try to cover is, and partly coming out of, I've been basically revising this as I've sort of sat through the best part of 2 days and thinking about where the conversation was going. So I've actually got a small bit on single fund holding, as that came up yesterday, and I was going to make a comment then, but I wasn't able to, so I thought, right, I better do that now. A bit on how to understand the problem, and a bit of my workforce work on mental health and diabetes, and just a bit of an economic evaluation we did of getting better at basically a diabetes program in Far North Queensland. I do a lot of work in a lot of my work actually isn't location specific, but where it is, I'm doing quite a bit of work with Congress in Alice Springs, so there's quite a bit that is in remote areas. Single fund holding, what it is, it's basically a concept where you bring into one pool funding from Commonwealth, state, health, other agencies, across program areas, across programs, across portfolios, into the one fund holder, usually operating at a regional level. In theory, it should maximise efficiency, because what it does is provide the greatest opportunity for resources to shift. At the moment, for decades, people have been complaining about stuff gets locked into programs, into portfolios. It's really hard to move them to where they're needed. So the idea of single fund holding is that would sort of free up those barriers. And it also puts a lot of focus on the community coming up with their priorities, what do they want to spend their resources on. Also, in terms of equity across regions, there's been some really important work when, for instance, New South Wales moved to a needs-adjusted formula to fund their regions, and that was hospitals and community health centres. At the time when they implemented that, they had some regions in terms of when they did some needs-adjusted capitation formula, with some areas were getting perhaps 40% more than they should, others getting 40% less over a 10-year period by moving over time, those areas that were more needy got more funds, and it's really important to achieve equity. It can work when we think about why have we had success in the motor accident area, and part of it is you have motor accident insurers who have the capacity to, they both get the revenue in, and then they can spread that money across whatever sort of program is going to make sense. So they can put that money into prevention as well as treatment. US Veterans Health Administration, single fund holder, did some fabulous work about a decade ago, really thinking about where should our resources be going, managed to then cover more veterans, improve their outcomes. They, for instance, set up lots of drug and alcohol centres, lots more primary care, so they were able to respond in a very basically evidence-based way. And it will radically alter the service mix. So Congress, it's not entirely a single fund holding model, so this is, they provide services for something a bit over 9,000 Indigenous people, or mostly Aboriginal people in and around Alice Springs. But what they do have a health service, they do chronic disease, health checks, etc., but they have a very large social and emotional wellbeing program. They have a public health directorate that does a lot of advocacy work. They do a lot of youth work. The Women's and Babies program has, for instance, a nurse home visiting. They do a lot of work in the early childhood space. They have a men's health that is very wide-ranging, men's shed, and a whole range of things. And this is basically run by a community-controlled board. You get a very different look when you have that sort of... and they do bring in funds from all sorts of programs, and they effectively broker them. But there are challenges, so vested interests. So there's a lot of people who argue against single fund holding. It will radically change the clinical mix, and it'll change where jobs are located. It won't suit everybody. Major challenges. How do you get the Commonwealth and state to put their funds into a fund holder, move away from their program-based funding? How are they going to announce the next major initiative into this particular program if all that's decentralised, even though when they announce these initiatives often means something else has fallen off the perch that was working perfectly well. And, are we really going to allow different regions to set distinct priorities? There's technical challenges in setting priorities and service planning. Scope, what sectors are to be in this? If we understand that a whole range of social factors affect health, do we pull that into the fund holding budget? Early childhood education, do we bring that into our fund holding budget? There's financial risks. How do we work out how we're going to pay? If we continue with the fee for service model, we can find actually the budget gets sort of overspent. So whereas under a salaried, you can sort of probably keep a bit more control over that. But there's different pluses and minuses with salaried or fee-for-service. How do we retain our Medicare principle? There's been a lot of work around, okay, is there a set of core services that every region would have to provide? Ensuring quality. Not a lot of difference to the issues today about how we ensure quality. And how do we skill up the community to actually participate and so that you get a genuine contribution from the community about what are their important needs. It's interesting in some of the Aboriginal communities where they have done a lot of work on understanding need. One of the things that comes up is the first priority is keeping our children safe. And that's as much a health issue as anything else. So the other thing that I think is very important is this whole problem conceptualisation for more effective and efficient solutions. So one of the things that I suppose in the last decade in particular I've been really thinking about, how do we close the health gap, particularly between marginalised and disenfranchised and the sort of mainstream. And my view is you need a deep understanding of the source of the problem, and where that's actually taken me is to focus on the family environment and the trauma load that sort of people both bring into the world and then sort of carry with them, and actually like a sort of snowball seem to attract trauma as they go. And in fact, the literature on this is becoming increasingly clear that trauma is toxic for the brain development, affects the trajectory of all aspects of the developing child and their life trajectory in terms of health, economic, social, and all these things then sort of compound and interact with each other. And the sort of trauma can be historic. We know it's sort of passed through generations, through sort of epigenetics and other sort of mechanisms. Current trauma, economic, social, things like dispossession, racism, family-based, and people with trauma histories are often then less able to really struggle to parent well their own children, not because that's what they want, but they're actually struggling with their own history. We've done some work in that space with a PhD student of mine, Jackie Amos, who's a senior child psychiatrist looking at these issues, and there's international literature led by people like Jack Shonkoff, who've been looking at this sort of role of trauma and what we need to do. Partly what we say is there's sort of a major intergenerational impact where histories of trauma result in abuse and neglect. The consequences then sort of entrap generations. So what we're sort of saying is we need to really focus on the child, the family environment as a sort of priority, so that we can try to push family, these sort of next generation, rather than being stuck in this sort of vicious cycle of child abuse and neglect, in physical and mental illness and all these things basically feed on each other. How do we sort of shift that family so that they can move into what's a sort of virtuous cycle where you get sort of positive outcomes, all reinforcing each other? And this is sort of similar. Basically, what it's saying is you get these sort of early exposures, negative consequences, psychopathology in childhood, adolescence, and we end up with a lot of mental illness. The developmental origins of mental illness would say if we got things right with families and children, we could probably substantially reduce our rates of mental illness. What I've got there in terms of the dollars need to go, it's probably inverse to where they actually go now, but this sort of work helps us understand what we need to be doing. If we look at, for instance, Commonwealth mental health payments, that big yellow band is disability support pensions, so half of Commonwealth support payments are going there. Something like our, what have we got here? Things like the Headspace, this tiny little red block, the Beyond Blue, a little purple block. This is what's happening now. State mental health payments. I've included child protection there, which I think is an outcome of poor mental health, which is the pale yellow. In terms of things like child and adolescent mental health service, that tiny sort of orange or bright red band there. So where services are needed is actually not where they're going. Health workforce, one of the things we've done here is looked at, for instance, diabetes. The challenge there was how do we conceptualise the problem in a way that's tractable but reflects on the complexity. What we then did was essentially set up this wheel where as we identify what type of diabetes does someone have, and then what are the complications. We add an extra layer, which is a sort of psychosocial, economic implications, both because that affects outcome and it affects the sort of workforce that we need to treat that. And then we sort of modelled that going forward, and what we find is if we compare our sort of current primary care team, where the GP is, say, this pale blue here, then under a biopsychosocial model that would be about a third what it is, whereas a lot of the things like your social worker should be substantially expanded because we've got so much sort of psychosocial stuff happening with this population. The same with psychologists needs to be expanded, and things like dietetics needs to be substantial. There's hardly any dietetics in the team now. That obviously needs to be substantially expanded. So this gives us totally different answers to where we should go. We've been looking at infant, child and adolescent mental health. We had a number of, again, how do we conceptualise need, using a whole range of data sources to do that, and then comparing it with existing services. What we were looking at is current psychological distress, high-level psychological distress, things like risk exposure. Most children with current psychological distress have lots of other rubbish going on in their families. We need to understand that. If we don't understand that, we're not going to put the right services in place. So again, we're going to have a biopsychosocial response to these issues. We also then looked at what's your sort of clinical care look like? What people do we need? So for instance, we're saying that with these families, we need psychosocial support. That's not a maybe if you can refer to someone who's actually got capacity. This is sort of core requirement for these sorts of children and families. And what our conclusion was that, for instance, we looked at South Australia. The Child and Adolescent Mental Health Service sees roughly 2% of children. Our needs analysis suggests it's probably 7% of children with high-level need. Current CAMS FTE is roughly 180. We think it needs to be more like 900. Current budget, about 24 million. We think it needs to be about 100 million. We are nowhere near providing the service for that group, and we wonder why we're not doing anything about disrupting disadvantage. Until we start doing something serious about mental health, until we do something serious about supporting families, we will never get there. So just finally, this is sort of, I suppose, the standard economic evaluation stuff we do, looking at a diabetes program in far north Queensland, about training individual health workers. We basically looked at costs and outcomes. The cost of this program was quite expensive, about $10,000 per participant. We looked at almost no change in mean haemoglobin A1C, some slight improvement. The top level is those with a haemoglobin A1C above 11.5%. So these were very, very unwell and poorly controlled people. Endpoint, the Indigenous health worker group had somewhat better outcomes there. But when we looked at disease progression, there was very little difference between the groups. A lot of people moving through to stage 4, so this is sort of advanced complications. So the program did very little to prevent that moving through. Hospitalisations, very little difference, some small difference in terms of our diabetes-related hospitalisations. Quality of life score, very little difference there. But it was a very expensive program relative to current costs. So in terms of cost effectiveness, very poor, something like $200,000 per QALY. Normally you want to be coming in at something less than about $40,000 per QALY. And yet often these are the sorts of programs where funding is these sort of chronic disease ones. So just to finish with sort of overarching themes that I'm sort of covering today. One of the roles of economics is one of the sort of mantras I use, that we're using policy-driven evidence to drive evidence-informed policy. Taking as a systems and logic-driven perspective, creative problem conceptualisation. If we don't conceptualise a problem correctly, we'll never get the best solution. We can do costing studies, cost effectiveness, burden of disease, workforce and services planning, looking at funding models. I think perhaps too much focus is on this sort of costing side and not enough on the broader, thinking about the sort of systems level stuff. I think it can be useful to engage economics early, help refine research question, contribute how best to answer that question, and then use economists in policy and practice translation. So thank you.